Here we go. Case number 9. Hello, Dr. Kini, in another room. Hello.
Oh, so case number 9 is LC, 81-year-old male, who actually had presented with exertional dyspnea and had a positive stress test. Now, along with the stress test, when he had an echocardiogram, he is another patient who also had a low EF with 25%. You see, he was on good medical therapy, and cath was done sometime in May, which showed that he had LAD, actually LAD CTO, OM CTO, and RCA disease. So, syntax of 33. So he was taken out of the room. He did meet the surgeon, and subsequently surgeons always ask that when you have low EF, totally occluded vessel, that before they open up, is there ischemia viability, which was done for their sake, and then all the territories were viable. And then subsequent meeting, he still refused CABG. So here he is for PCI. Initially, we were thinking that we should do the RCA PCI followed by...
Can you show us some of the angiograms so we could see?
Yeah, you can see now. This is the LV gram. What is the EDP?
Wow.
25.
Yeah, and EF, this is the EF with the EDP of 25. That's right.
And you have viable myocardium somewhere?
Everywhere.
In the CTO and everywhere.
Play next. Go next.
No, where's the right? That's all you did?
Yeah.
Okay, this is the right coronary artery, which you see about a moderator, I would say 60-70% disease in the prox to mid. And the angiogram that was done before, if you see there,
yes.
Mid, which is a heavy calcium, but I would say what that connecting that is all bridge collateral.
Uh-huh.
And then you have there's an OM that is totally occluded, which you don't have a picture, right?
We have one.
Okay, here.
So
that led to another totally occluded obtuse marginal.
right. Oh boy. Okay. And the patient, obviously with the EF like that, the surgeons are not taking the patient, or?
Yeah, surgeon said, no, I think after the discussion with the surgeon, once they give them whatever the risk that they give, he definitely refused.
Oh, the patient refused.
Patient refused, yeah. So here we are for the PCI of the CTO of the LAD.
Okay, so we have severe 3-vessel, 2 CTOs, even the right coronary in that proximal area looks like there's some lesion there as well. We can talk about any comments about the current strategy, going after the LAD. It looks like she's going to go antegrade. We're going to talk about antegrade versus retrograde. I think you always start antegrade, is that right?
Yeah, always start antegrade, first attempt, second attempt. In very rare cases where you think there is osteal occlusion, there is osteal right, osteal LAD, and you have good collaterals, then primarily you want to do retrograde.
Okay, so we have a great panel here. Why don't we start with John La Sala? What would be your strategy? You like the Impella?
Let's get the Impella off there.
Well, it's a low enough ejection fraction, so you'd be concerned about it. Impella for CTO is probably more important if you're going retrograde, because if you're cutting off some of the collaterals, you have a higher probability of a larger ischemic zone and more decompensation, but certainly reasonable in this situation. The nice thing about the CTO is you've got, it looks like a calcified tract there to follow, which in addition to your retrograde flow will hopefully direct your wire into the right spot. I mean, your proximal cap is a little bit indistinct because it's coming off right at the diagonal. So that's one thing not in your favor, so you may be looking at a possible dissection re-entry.
Dissection re-entry. Dr. Bhatt?
I think this is a really logical approach. I mean, I would have pushed the patient towards surgery as much as possible because LV dysfunction, triple vessel disease, demonstrated viability. I mean, there's mortality benefit. But if the patient really was refusing, then I think the PCI makes sense. It's a support device. Probably fine for peri-procedural use. You know, it's interesting. Many years ago, Gilles Montelesco, I don't know if he's still here, but
Gilles is on the panel.
Oh, is he here? I can't see who's
right on your panel.
I don't know if you remember this, Gilles, but when you visited many years ago Cleveland Clinic, you were telling me about a case you did, which was an unprotected left main through the radial approach with a 6 French guide. And at that point in the U.S., no one was doing a radial, and we were doing unprotected left mains, but 8 French sheath, balloon pump support. And it made me realize that even times where I thought support was needed, oftentimes it ended up not being
So
needed.
as we discuss what we should
So is
do,
this a
she
CTO
already
or fake
crossed the
CTO?
lesion. Is this a CTO or not really?
Or maybe fake CTO. We call it now fake
There was,
CTO.
there was a small channel there.
Alternative facts. No.
There was a small channel there. You could see that as long as it wasn't like bridging
What
collaterals.
was the wire you used?
No, this was just a regular fielder, and if I think as mentioned by Dr. Lasala, the proximal cap, the interesting thing here, yeah, we are in the distal vessel.
What wire was this, AK?
No, this was regular fielder.
Okay.
Fielder.
Yeah, the
Even not
tip
fielder
load for
XT.
this about 3.7.
And that's a fine cross?
Yeah, so now the same, if you would ask, if you go back here, when you're seeing the CTO,
There's a small channel.
so this is where you have a large diagonal, and then you have the proximal cap. You may think that it's a lot of calcium. So either you always try with your fielder wire, or even this is a good case where if you want to try fielder XT, or even you want to try your pilot 200, whatever wire that you think that you are comfortable with, this is a good case that you want to start with that wire. And if that does not go, then you go with the escalation where you want to go with your drilling wires if you have not made your way through. So
Anu, I am already getting greedy here. The way you pass through the LED, I think you could even consider doing the OMB after this.
OM, if Dr. Sharma gives us enough time.
So,
Now this is where we may have trouble if getting
yeah,
the
it looks
fine
like
cross
your
across.
fine cross may not go.
Yeah.
Yeah, this is where I do favor a microcatheter. It's got a little bit more body, and you can torque a bit. The fine cross is nice for
A
tight
very
lesions.
interesting point, because not a bad choice. That remember we favor going with 6 French. Many people go with 8 French catheters so that they can go with this micro catheter or even a Corsair up front, so that when you face this kind of this is you see that calcified CTO, that if you think you have trouble, you already have Corsair in your hand to traverse that CTO. But we will show some other ways to do that. That now, if I think I cannot now, not a bad choice, that you can still rotate the fine cross, and same thing I'm trying to advance it. If it does not, then give me a 2.5 balloon. We'll anchor it, take it out, and go with a guide liner and a 2.0 balloon, which should, or 1.2 balloon. That's the smallest size balloon that.
You can use a
Yeah.
Euphoria balloon. We call them the pink balloon. They
Or
actually
the threader.
sometimes-
Threader balloon is.
The threader seems to be a good balloon that I've used a lot.
Yeah, threader has
So
an interesting.
just to go with the wires is the same, the first set of wires that you want, either your Miracle or the Gaia wires, because Gaia wires have now becoming a favorite of many of the CTO operators. It is a new wire family from the Asahi family, which has a composite core. They use the word what is called as a composite core, where they have, if you see that the core of the wire has what is called as a braided look. So what happens, your one-to-one torque is transmitted and usually deflects away from the lumen, tries to stay in the lumen, deflecting away from the wall. So this is what we call, you can do. So here I went with a 2.5 balloon. It's going to go up. So you anchor, the fine cross is out. We are anchoring the wire. So the fine cross will take out. You went up, right? How
Yeah.
high? Up, well. So you can either go with the Miracle or the Gaia wires. If then that is done, then you go with the Confianza family. Down. That. Get me a 1.25 balloon. So the 1.25 is same. You can use a Sprinter Legend, or you have the 1.26 or 8 millimeter Trek balloons. Mini Treks, yeah. You have 6, you have 8. You can carry any one of them. Then of course we have Apex balloon also, which comes from 1.5. Once you have done this trapping, always make sure you pull back, because there's a lot of air trapped in the guide.
Show us all the details of the trapping, please, here for our audience. You finished it already?
Yeah, done.
Yeah.
Ui. Can
done.
you give a guideliner?
But if you would not be able to pass any balloon and you have just the Y, would you consider to do rotational atherectomy here?
The only question here
Or
is, I
laser.
need the rotor wire across. The fine cross didn't even make, did not traverse any part of the CTO. Question would be, could it be a case for laser if nothing goes?
Right.
If laser doesn't help either.
Yeah, but native vessel, I'm a little concerned about laser because of the risk of perforation.
Yeah,
But
well,
it's
the
something
laser
to think
generally
about,
doesn't-
though, no?
The laser generally doesn't go through it, but it will fracture the proximal cap.
Proximal cap.
Yeah.
That's true. It does
That's
help
the
you to
point.
penetrate with the balloon after that.
Okay,
And then she can go
Give me
in
the
with the
guide.
balloon.
The other nice microcatheter is the Turnpike LP. I find that to be the most.
That's what I've mentioned several times
That's a
already.
good one.
And you could really torque it
So there are
through.
many options for transit catheter today.
Yeah,
support
nowadays there are a
catheter.
lot. We have the Micro 14, which is from Roxwood, which is a combination, they say, is between Fine Cross as well as Corsair.
I wonder, why did you try with Fielder FC in a case like that? I mean, did you-
Fielder, yes, the tip load is smaller. I think Fielder FC tip load is just about 1.9 or so, very soft. I think if I was going to go retrograde, I would have tried a Fielder FC. Okay, so I have the guide liner if I need be. Same thing, do not get the guide liner into the left main or any part of the proximal vessel until you really need it. You can leave it in the guide. So we are going with 1.25 balloon, which is a Sprinter Legend. Same, if you do, this is 1.26 millimeter balloon.
So the marker is in the middle,
Middle,
and that allow you to
In the
penetrate better.
first 1 or 2 inflation, you'll never see the balloon. So let us see, same, not going, heavy calcium there.
It's so much calcium, I wonder if you are going to need rotational atherectomy or
Well, eventually, I
even
think,
orbital atherectomy
if
or
we
something.
follow the theme of this meeting, you need to at the end of the day.
So now let me advance the guide liner into the guide, we're all the way there, proximal, and
near-
now try to,
So now here's where you're glad you have an Impella if you're going to use a guide liner, because the potential to get ischemic at any of the side branches and
Okay.
proximal LED has now
Yes.
just gone up.
What balloon is this?
Legend, I think.
16, 18.
Legend or
1.
track.
It's the Legend balloon, Dr.
Down.
Kini?
Yeah, no, this is a, Sprinter Legend, you see it open 1.25. So what I did, I think I entered a little bit, so you dilate it, trying to go further down.
There's another risk with guide liner to cause dissection, so that's
Yeah.
another
So,
good reason
yeah.
why.
It's a good reason to have that backup. It's a good reason to have some backup.
The other balloon I find useful here is the push, Apex push.
Apex push, yeah, we mentioned that.
That's what it's made for.
What size you have apex push?
You're against the rock there, that's for sure.
Though that guide liner dissection risk is a little bit minimized if you always lead with a balloon and not ever lead with the guide liner itself.
Oh,
Okay.
But you see, she's
Yes and no.
really having a hard time passing that tiny little balloon across. You wonder what
Apex
is
push,
going to
you
be
mean
your
1.5?
next.
1.5 may not go. Okay, go up here. No, apex doesn't come 1.25.
time for the microcatheter.
Yep.
Okay, down.
I-
I think we all, I don't know.
I think a laser is.
Laser is
Want
the
to try
first
laser?
way to go here.
But you need to warm up the machine now, it's another 20 minutes.
She's
Okay,
gonna
start
go
warming up the machine.
Start warming up the machine. In the meantime, you'll have all these
Look,
other.
one of the reasons I think laser makes sense here is because it's a very straight shot. You know, there's no tortuosity. You don't have to use the smallest size, I think, which is a 0.9.
Yeah, I agree. I mean, it's very safe to do this with a laser.
The
Yeah, I
only
think
challenge
there
would
should be
be
no
that
problem.
if there is any micro dissection, then you could virtually run into trouble. But
Yeah, 0.9 is pretty safe. And you really don't need to cross the lesion, you just need to warm it up a little bit.
Okay, let's try some of the laser machine is coming. Okay, give me 1.26. We'll try 1.26 mini trek now.
Also, let us know if you want us to go to another room at all.
No, we want to see her cross.
No, we
They all
know.
want to see the steps for this.
We want to see all your steps, but, you know, the laser takes a while to warm up, is what I'm saying.
No, meanwhile, we are trying the different balloons.
Okay.
So we are trying 1.26 trek, and after that we will have the apex push, but apex push is 1.5. So if we are having trouble with 1.2, I don't know if 1.5 will go, but still we'll try it. We have 1.5, 12. You don't have shorter than that, right? Glider will not make it there, no.
I think you most likely will be able to cross it with the rotawire. I mean, it seems to be.
After all this, she was
Yeah.
did such a good job with the regular wire. I bet the
And
rotor
if
will
not,
go.
you can recross again with the filter. But because sometimes that's the, if you really don't want to use the laser, that would be the best way to do it.
Okay.
But why not? Maybe the laser, this would be a great example to show the laser, because we haven't shown it.
Should
It
we?
would be great.
That's one of the few indications that remain in the coronary for laser.
Some dye here.
The other one was
How does
thrombus
that-
management. It's actually dissolving,
Okay.
vaporizing thrombus.
No, this, oh yeah, okay, good, good.
Well,
Which
sometimes
balloon was
for a
that? It
very
didn't do well at
underdeployed
all.
old stent.
Sorry,
Although,
Deepak,
Ron, I would.
Oh, no, I was just saying,
qualify-
another use for lasers, if you have an old underdeployed stent and you can't
Sure.
expand it, you can sort of use the laser to explode it open.
Yeah,
But that can be a little
With
risky.
contrast.
that's right.
Yes, with contrast.
Ron, going back to what you just mentioned about the use of laser for thrombus, I would qualify there more of a organized thrombus rather than fresh, because the fresh thrombus, it'll just daughter through it.
Pressure.
Why, what happened to the pressure? Radial pressure.
So one of the talks today is on radial intervention. We have yet to see one, Dr. Kini.
Well, I think this is actually a very good demonstration that radial is not for all patients, because this is a very
Exactly. There you
complex
go.
cases. This is not the bread and butter cases that
And
are done
all
in
of the
lab.
cases in this lab
So
and
none of these
everything we
cases,
saw
I would
today.
say, would fit radial.
Roxana, we
straightforward.
do have contralateral access via radial.
All right, excellent. Good job.
Well, you did the radial for the Sentinel device, so that's counts.
Yeah, there you go. So tell us what you're doing, Dr. Kini.
No, I think we are getting ready with the laser.
So
I mean, we
did
could
you
try-
try the apex push, or you just don't think it's
No, I
going to
don't
be
think it's
worth
going to
it?
do anything, no.
Yeah.
My experience that if the mini tracks don't go apex, okay, give apex push while we are waiting for the thing to get heated up.
Well, anyway, we have to wait for the laser to be ready, right?
That's what I'm saying, but it's going to be
Why
a
is the
nice
pressure
demonstration of
variable? Guys.
laser.
What is happening with the pressure here?
Even after laser, you
Pay
only have to
attention to
load
the
up.
patient.
So calcified.
Why there is no pressure here? What was the ACT? Okay, can you, there's no pressure, guys.
Flora?
No, I took the
guideline is
guideliner out. Both radial, everything is no pressure there.
But he isn't.
Guys,
What?
are you okay? Mr. Conte,
You can look fluoroscopy on the squeeze of the heart. It's,
Is the Impella
How about
in
the
order?
Impella, the Impella should give you a mean.
wake him up.
We don't have good flow there.
Yeah. Huh? No, why you don't see, guys, stop the laser, just check why there's no pulse
Check the pressure.
And just check your coronary flow.
Start CPR.
Yeah, maybe take that
we need to see
I have everything
guideliner out.
No, I do not want to
Guideliner's
do
out.
anything. Guideliner is out for a long
Need to see a
time.
picture and see what's going on.
No, you cannot inject anything. Your first thing you have to rule out is
There,
any
now we
thrombus.
good. Okay.
Yeah, maybe bleed out the whole thing.
First thing, you do not, in this situation, never inject forward. If there is any thrombus formation in the guide, I think there may be thrombus in the guide.
So you're bleeding it out now?
yeah, but if that's the case, you probably like to take the whole guide out, to wash it, and to re-engage.
You're bleeding it out. What did you say ACT was?
And the blood pressure is okay?
386. Check another ACT, Rama.
Is there a cuff pressure at least that someone can obtain in the room?
The radial pressure should have been accurate, though.
Yeah, on the other side, your radial, contralateral radial.
Both are damped.
Oh, okay.
That's the thing.
You have three ways to measure.
And remember, this is a CTO case, so you always have to worry about perforation and tamponade, so all those needs to be, you can call echo to the room, you can
Patient's okay?
look fluoroscopy if there is any shadow of white.
Are you in the mean?
Can you show us the hemodynamics?
Show the hemodynamics down there.
Let's look at the Impella.
And maybe just fluoro the cardiac silhouette.
It's moving.
There.
There you go.
What was that?
Just move the Impella.
No, it's nothing to do with the Impella. This is here.
Yeah, the heart is moving, so there is,
Now we got it back.
you want to make sure you don't have
Here
any
it comes.
tamponade there.
Okay. I mean, EKG, there was no change.
It is, though, that you see that the pressure tracing is not optimal. I agree.
I would call echo, just to make sure that there is no.
Okay, we have the laser ready?
Are you going to take a picture or no? Still.
See that?
Yeah.
I always try to figure this out
Look
before.
at the Impella again.
Yeah.
No, nothing to do with the Impella. This is pressure tracing here.
I mean, the cardiac silhouette looks like it's moving very nicely. Can someone do a cuff pressure for you?
So it's the guy. It's something.
Where's the cuff pressure?
Patient is awake?
Patient is awake
He's
talking.
responding.
Okay.
Guys, you cannot figure out? I don't know, there's damped pressure consistently.
Yeah, I don't think you can do anything until you figure that out. Do you want us to go to Dr. Sharma or no? I know everybody wants to stay with you, believe me. But if you want us to go until you figure out what's going on, I'm open to that.
That groin's okay?
So the pressure tracing on the right coronary artery is okay? If you back that out a little bit?
Yeah.
Impella is working now?
Impella is
But
working.
vessels are open or what?
No, we didn't want to
There you go.
inject forward until we know that there is any. Now it's on and off pressure. Where's your cuff pressure?
Cuff pressure is still cycling from the last time. Still coming down.
These guys. No, why is this guy bleeding like crazy here? Huh? No, nothing to do with pressing. Okay.
We did the laser?
We may have to do the laser because
You want
nothing
or you
is
have
going.
done it?
No, we're gonna do it now. Can you hold it? Hold it. We need to calibrate.
Okay, now you see that.
You want to show some pictures? And you
Coronary
want,
flow is good.
then you
You
want
see
me-
that? Again, you lose the pressure as soon as we.
Let's check the right coronary flow.
No, right coronary is okay.
All your hookups are still tight?
Should we take a, while your laser getting ready, you want me to, not ready yet?
No, we are worried about this hemodynamics here. Forget.
Yeah.
I mean, it looks the same.
Good.
The right.
Laser is ready, we heard it.
We heard the laser, right? But I do agree, though, if you don't have good tracings, it's hard to move ahead with lasing
No, now it's okay.
without
No,
tracings.
no, that's the way. Then it damps, completely damps. I took the guideliner out thinking maybe thrombus, but nothing there. I give an ACT.
But the RCA is also the same? The radial...
RCA looks the same.
No, the radial A line is...
The pressure tracing
Both
from
are
there.
getting damped. I think it's something wrong with the system here, I'll tell you.
So do we have a cuff pressure at this point?
Yeah, cuff pressure is 113 by 90.
Okay,
Oh, okay.
that's good.
So it may be the transducer got
There's
busted.
something with the transducer.
But both?
But why can you have both transducer trouble?
I
Something
think
there?
it's something with the... No, don't flush.
Dr. Kini, do you want to figure that out and let us go to another room, or what do you want to do?
I think you should do laser first.
Okay.
If
We'll
after
look
laser
at it
you want
with
me to come
cuff
on the side?
pressures.
You want to get some echo team quickly meanwhile?
For what?
Then what they were talking about pericardial effusion?
No, nothing. They're just saying that you have to have. Okay, we have the laser ready to go now. Where's the thing? Give it to me. You have to have the flush, right? Who has the flush? You cannot have a dye, right? Only saline.
Only saline, and you're going to give 1 cc per second. Or you can just turn the flush on with your. No, that's too much.
I'll do it.
1 cc per second.
Yep.
Okay, no dye, only flush. Okay, guys, so this is our slow injection as I'm going forward with the laser. Okay, wait. Okay, I'm at the proximal cap there, right?
Yeah.
Okay, go. Slow
We
injection.
see it.
Go.
Yeah. Inject. I'm going with the laser. Are you ready? Yeah, 50-50. I don't see. I'm pressing.
Doesn't look like it's going anywhere.
Exactly. Okay, let's see. Ready again?
Yep.
All right.
Wow.
All right, Dr. Kini. You want to go a little slower than that or no?
No, I know. We should be slower.
She can go fast if she's not lazing. That's okay. That's
No, she
that's
was lazing. I was hearing the
But
laze.
it's good. We see you smiling, so we smile.
How's that pressure tracing going?
No, pressure tracing is making me nervous. It's back to the same thing.
Good. Let's dilate.
Wake him up.
Anu, can we take one picture here to see
Yeah,
how?
we'll see.
Well, wait, let her bleed it back and all
yeah,
that.
2.5
Good
angio's
things now.
Read that. You have a 1.5 balloon?
Yeah, but they're daily. Oh, that one. Yeah, we dilate both of them. Yeah.
Yeah, 1.5 and
Just put a
1.5.
V.
Okay, 1.5 apex push.
Or maybe diagonal further down.
Okay,
Good.
let's see.
Okay. Yep. Now, which one is the wire?
Okay, I think we will just balloon this and put a stent across. Right,
Yeah.
guys?
Definitely. Looks good.
We can. You have a 2 or a 2.5?
Let's just show us that a balloon is going to go, actually.
Okay, we will. We have
That's
now
all we
what,
wanna see,
what balloon
that-
you have?
And
The
redirect
laser
the
actually
wire
did
to the
something.
main.
So we have a 1.512 apex pusher.
I think a 2.5
2.1.
balloon will go now.
No, we had
Your
2.515.
distal vessel looks cooked, you know?
Cooked?
Yeah, like, you know, I see some lines, maybe dissections.
Yeah, you're right. The laser. Okay, yeah, it's going. See that?
Wow.
Nice. Okay, open here.
That's just the small balloon, right?
Yeah.
Now you'll need a big long balloon, I think, like a 2.5 long, no?
In patients like that,
2.530
if
balloon.
the end diastolic pressure is high, sometimes you don't see a good flow.
Go
So
up here.
Yeah, also when you have both
that's again another
injections.
advantage of having a right heart monitoring.
Go up here.
We just want to see you put a 2.5 balloon across there, and then maybe we'll go to
Now
Dr.
get us a
Sharma's
3O
room.
now. 3O20, high pressure balloon.
Good.
NC?
Then you can, when we insert stenting, you can go across.
I'm thinking you need a 30 millimeter balloon.
Okay, flow is good.
You need a long stent here.
Long stent, yeah.
We take a 32, 38. Agree?
Start with 32.
Yeah. At least 30.
Roxana, with time, sometimes we forget, but one of my earliest papers was the use of laser for undilatable lesions in 1991.
Oh, wow. Yeah, well,
Yeah.
here you go.
And
Here's
that
the
was
one.
all the work done with
It's a really
Jim
good
Margolis.
example of how laser can help you.
Look, the real, I think, that was the comment which I had made earlier. If you had some tortuosity there, that was not the device. But with this looked a pretty straight shot.
Yeah.
Wow.
Okay, now same, we don't need the right-sided catheter. Take it out.
18, 20.
The other important point, when you have contralateral injections, once you know you crossed it,
Look at
you
that.
can take it out. Yeah, go.
That's
And
really
the other-
amazing how the laser just really opened up. I
Other
think it was the
Roxana,
proximal
another,
cap. What do you think, Deepak?
Another
Yeah, I think it was a great use of laser, really useful.
7.5,
Yeah.
30 to
Dr.
Roxana, the other, if the laser would
What
not
happened to
have
the,
gone, I would have recommended her to slightly pull back the wire because it somewhat helps you
guys can't
advance.
figure out what's wrong here? Go.
How's the hemodynamics? Good? He's
Talk to him. What did you sedate him with? Okay, go up here. That's good.
good.
That's where I think there was disease there. See?
Yep.
Good. Down. Okay, now we decide about the stent length, and then you guys can move on to the other room.
I think has to be more than 30 millimeters, but take a picture.
Ready?
That was a 20 millimeter balloon, right?
There's a 20 millimeter balloon. I think we can take a
So like a
32
33
stent,
or 32.
Yeah.
Wow, nice.
38.
It's
38.
stent-like
35,
result.
38.
Yeah.
And we are going to stent
What
across
size you going?
3.5.
3.5, really?
This is a low mag.
That's a little bit aggressive.
That's aggressive, I think. 3.0.
You can always say it.
You could post dilate. It's
You
a
can- you
tapering
can take the
long
Okay,
3.0
give us a 3.0.
Yeah.
I
This
love
is a
when
low
you listen to me.
magnification.
Yeah.
That was good advice. It's a 3.0 downstream.
What do you have there? 6 French?
This is a 6 French, low
Yeah.
magnification. We are
3.0
at
is good enough, yeah.
20.
3.0 will be good. You
I
are
tell
right
you, with
about
the long
proximal
stents,
vessel
you can just
3.5.
taper them, and as long as you don't go high, you can still.
Okay.
But I think you'll still go up with the post dilate to on the proximal side. You're right. It's a 3.5.
It has a great blush and good distal flow.
Looks really good. How's the hemodynamics looking?
Good.
Why we don't believe you, Joe? You see,
Once you
that's
come up-
exactly the length you needed. Pretty long stent.
No, we are going to go across the diag, okay?
Yeah.
Because it started before the diag, right? Everybody agrees
That's a good
now? Yeah,
spot
go up.
right there.
Go up.
So this was 32, right?
38.
38.
38.
Wow, that's long.
Good. Good. Down again. We did a fluoro save. I think the other thing that we all interventionalists have to be worried about is our radiation exposure. Down. Down.
It's down.
Okay.
I gotta go up again.
Okay, go. Oh, wait, came down.
And the
take it
strategy
out.
with the Impella would be to leave it for a few hours or to remove it immediately after the
We'll
procedure?
take it out here
Yeah.
in the lab. if
She
everything
usually
looks
takes
good.
it right out there. Wow, that's nice.
Okay, we have some work to do. We'll recross the diag.
Get a run through.
No,
The diag.
field.
Yeah, but you see the diagonal is there.
Yeah, but you can open that.
Yeah.
You'll
that
open
will
it
open,
right
we'll
now.
kiss balloon, and we are good to go. You can go to the next room with Dr.
Yeah, and we'll
Get
come
a
back.
2.5
We want to
There's a
see what
pretty
you
good
do at the
collateral to
end,
that
okay,
diagonal.
Dr. Kini?
No problem.
Yeah, show us. But you see,
Run
that's
through
why
and
it's
then
great. You have Impella. Is there ST changes or?
Nothing. Rock
Okay.
solid. No EKG
Rock
changes, but
solid.
no blood pressure.
Okay. Okay, excellent. Let's go to the other room and we'll come back to you. Thank you, Dr. Kini.
There we have our diag back.
I'm not loving that flow.
That's a good flow for that kind
Let
of
me
LV.
see.
So this is where it was. See, we completely lost the diag in this view, right?
Yeah.
Nothing. You don't even see the ostium. So try
Okay.
to go
Collaterals.
cranial. You see that?
Yep.
But would not go with the fielder. Then took a whisper. You see, fluoro saved how we crossed it. So this is where we were deciding. Maybe we have to do the pot. Remember, since morning I've been telling how we have to get a pot. This is a case
then you
where
got
you
it.
think that if this wire would not have gone into the side branch, then we do a pot, make an proximal optimization, and then try to get into the side branch. And then we just did a kiss balloon.
That's
This is a
good.
kissing balloon,
Okay.
and this is where we are.
Oh, wonderful. Good.
Yeah, I
So-
think the side branch looks good.
What are you going to do now? Are you going to do a little bit more prolonged dilation in that side branch before you
We'll see.
leave
I
it?
think
Because it doesn't look perfect yet. I'm
That's
not
the way
loving it.
That's the way usually the provisional, when you do a provisional stenting and you have a side branch, the ostium, that's the way it looks. I think once we take out the wire, we have 2 balloons, 2 wires in a 6 French guide. That's why the flow is
Yeah,
not good.
I think you're done.
Huh?
You're done.
Yeah, we are done. So we
Okay.
take out everything and
You feel good?
look
Everyone
at the
feels good about this? We
Yep,
retrieve
time to
the
get out of
diagonal.
Dodge.
You would leave it, LIA, leave it alone, yes? Okay,
Yes.
beautiful. How's the hemodynamics?
Okay, now you can show the hemodynamics. Now we finally found, because
What was the problem?
yeah, Impella was at a full force at 3. What was your pump going at?
P9, now it's I went to P5, P4.
No, yeah.
You think the
P9
Impella
is
was
what,
in too
2.5?
far?
0.5, yeah.
Yeah, we were at P9, which was 2.5 cardiac output, and that's why his pressure was going lower and lower. Then we decreased, now we are at P5 with the cardiac output of P4,
Dr. Kini, what was your LVDP to start with?
25.
Okay, so you may have actually, in the length of the case, driven it down quite a bit, and therefore you're
Yeah.
spinning
That's
too
probably
fast.
what happened, yeah.
Okay, got that. All right, very good. Excellent. So you're done here.
We are done here.
Okay, we'll go back to Dr. Sharma. Thank you, Dr. Kini.